Hello, I'm Dr. Sarah McWilliams, one of the consultant breast radiologists at 108 Harley Street, and I'm going to talk to you about contrast-enhanced spectral mammography, which has more recently been just called contrast-enhanced mammography, so the spectral aspect has been dropped. So what is contrast-enhanced spectral mammography? I'm going to talk about this morning why we need contrast-enhanced mammography and how it works, and how we're going to perform it, the current and potential indications, and to compare the more known technique of breast MR with contrast-enhanced mammography. Why can't we just rely on mammography itself? Mammography is a reliable tool, but it has limitations. The main limitation with mammography is that dense breast tissue can overlap lesions in the breast, obscuring them so they're invisible to the eye. The interpretation of images is very different again between radiologists, and it can be very difficult to see small lumps in dense breasts. And if we look at this, the four types of breast tissue that we have classified here, we have fatty parenchyma, sort of a BI-RADS B. This one is a mixed and a slightly more mixed for slightly more dense breast tissue. And this is the very dense breast tissue where the background is very white. And so in this white background, it can be very hard to see a small white lump, which is much easier in the gray fatty background. So how does contrast-enhanced mammography work? Well, in theory, it looks like you're just doing a standard mammogram because you're going to just take 4 images, 2 of each breast, as we normally do. The difference is that the machinery has been specially adapted so that when we expose one breast for one picture, we obtain 2 sets of images. It's very clever. 2 exposures are delivered. One is like as a low kV exposure, a low energy exposure, like a standard mammogram. And at the same time, a higher exposure kV of 45 is emitted. And therefore, we end up with 2 images, a low energy image, like a normal mammogram, and a higher exposure image. And the only difference is that before we take the mammogram, we're going to give an injection intravenously of contrast, an iodine-based contrast, which is exactly the same as we would use for a CT scan, which has become our workhorse in all aspects of imaging. And so if we look here, we give our injection at time 0, which takes a couple of seconds. We cannulate the patient and then inject the contrast. We wait 2 minutes, and then we take our 4 pictures, as in here. And each time, if I just remind you, we have 2 exposures, a low energy and a high energy exposure, but we're only positioning the patient 4 times. What is the theory? Why does this work? Well, it's exactly the same as in MRI, that in cancers or worrying lumps or in any lump, they have an increased blood supply. And the iodine is taken to the lumps or the abnormalities because it has a greater blood supply. So it's based on the neovascularity or blood supply. The extra iodine flows to those areas and therefore stands out. It's based on blood flow, which is exactly the same principle as used on breast MRI. So the sequence would be, we get the 2 images at the same time. So we give our injection of contrast at time 0, and then we have 5 minutes, between 2 minutes and 7 minutes, to get the 4 mammogram pictures. We start imaging at 2 minutes, and there's a 5-minute window to take the images. The difference from the mammographer's point of view is that when they expose the patient, it's a long exposure, as it's taking 2 exposures, low kV and high kV. 2 sets of images are obtained to get 2 for the price of 1. The first image is diagnostic quality, like a routine mammogram. The second image, the higher kV image, shows the contrast-enhanced areas only, which we call the recombined image. And this is all based on clever physics around the K edge of iodine being 33. And we can see the low dose and the high dose. The standard mammogram equipment has been adapted to include a copper filter and the special energy software, which is what we will be using at 108 Harley Street. So in practice, the test takes just over 5 minutes. We do need to cannulate the patient, but that's become very routine now with the wide use of cross-sectional imaging everywhere. We need to be mindful of the patient's renal function, as we do in any MRI, CT, exactly the same, the GFR of the patient when we're injecting contrast. And like all iodine-based, we need to look at allergies to iodine and asthma and just do our allergy check. Again, this is a routine thing. So ideally, what we would like to do with certain population of patients is to replace the standard mammogram and do the contrast-enhanced spectral mammogram. Initially, we will inject 50 mils of contrast, and then we'll wait 2 minutes and do our mammograms in series. The risk of a contrast reaction is the same as CT, so when we're well trained to deal with it, this is something we're routinely used as in an imaging environment. What are the potential indications for contrast-enhanced mammography? Well, something being studied currently is, can we use it for looking at patients recalled from screening when they present for assessment? And this is being evaluated now in worldwide trials. The current use, though, that is being used, has been adopted in many centres in the UK and worldwide, is the symptomatic diagnostic setting, where patients present who are young with cancer or dense breasts, and there's a diagnostic challenge. Contrast-enhanced mammography is an excellent problem-solving tool in this population. We can also use it for surgical planning and for looking at response to neoadjuvant chemotherapy. And these techniques may replace, we hope, the need for breast MRI. And there is some work in progress looking at, can we use contrast-enhanced mammography to screen high-risk women or women with dense breasts? I now have some cases to present. This is case F. This is a 34-year-old patient who presented with a lump in the right breast. And as is the standard practice in this under 40 population of 34, the first line test is a breast ultrasound. And ultrasound showed a sort of 8 centimetre multifocal mass and was graded U5. When the mammogram was taken, there was only a 4 centimetre lump because the breast was dense. Whenever we find malignancy on ultrasound in an under 40, we would proceed to mammography to see if additional information can be obtained. A contrast mammogram was also performed to see what was revealed, and the contrast mammogram did show indeed 8 centimetres of enhancement, and this was a grade 3 tumour. I'm going to show the images. This was one of the pictures of the ultrasound, this irregular mass in the right upper outer quadrant. This is the difference. This is what looks like the standard mammogram image on the left, and on the right, what is the recombined high energy second set exposure. We can see on the standard image how the background is so dense that all we can see is this lump here, which sort of matches the thing we saw on ultrasound in the right upper breast. But when we look at the recombined image, we see other foci of enhancement here in the breast here. And on the craniocaudal view, it's more clearly seen. This is the dense breast with a vague impression of a lump in the outer part of the right breast. The breast is dense because the patient's young. On the recombined image, again, we see the anatomy of the cancers far more clearly, and we can get rid of all the dense background. And this obviated the need for MRI. This is another patient, a 65-year-old patient, who presented with a left breast lump. The first test at 65 over 40 would be a mammogram, and this showed 10 centimetres of distortion in the left breast. There was lesion discrepancy on ultrasound, as only a 25mm U4 mass was seen, as in here. So this is the mass on ultrasound, and it is irregular, and it has been graded U4, meaning suspicious. We went on to do a contrast-enhanced mammogram to see if we could define the anatomy. The biopsy of this showed a grade 2 carcinoma, but this is just to illustrate the information we can obtain on the contrast mammogram. This was the standard mammogram, oblique view here and here on this patient, the two views. And we can see this density on mammography, but it's hard to tell if this is glandular parenchyma or a mass itself. On the recombined image, we clearly see the 3 masses in the lateral aspect of the breast and their total extent. And likewise, on the recombined oblique view, we see the layout and the anatomy, and this age surgical planning and further biopsy, and obviated the need for MRI. This next patient is 53. Her first-line imaging with a right breast lump would be a mammogram. On the mammogram, we could clearly see in the upper breast this irregular spiculate lesion causing indrawing of the nipple, and a marker has been placed at the biopsy site. Ultrasound was performed. It showed nothing on the left, but on the right, 3 centimeter irregular mass. Let's look at the recombined images. So this is what we see on the mammogram, the standard image. But when we look at the recombined contrast form, we can clearly see the limits of the mass and define it and get local staging far better. And this is what would be a matching picture if we did an MR of this. And the other thing we get is an opportunity to look at the other breast. And in the contralateral left breast, we saw this little irregular abnormality here. The patient did indeed have an MRI, because sometimes we do MRI to check that what we're seeing is what really is happening. This shows the right breast lump on the same patient behind the nipple of 3 centimeters. But interestingly, the MR also shows a little area in the left breast, as did the contrast enhanced mammogram. And when this was biopsied, this was a grade 1 cancer, and a grade 1 on the right, but a grade 2 carcinoma on the left. So the contrast mammogram actually did a good staging on the right, giving us the correct size of the lesion, and then it screens the left breast and enabled us to see a small lump we would have missed in the other breast. And when we did the MR and the contrast mammogram, the size correlation was perfect. So we felt this was increasing our contrast enhanced mammography level of trust. Another patient, 35. So her first line test would be ultrasound with a breast lump. We saw this ill-defined mass in the left breast, and it was graded U4 with calcifications. She's gone on and had a mammogram and a contrast mammogram. So if we look here at the mammogram, the reason for the mammogram, one of the indications for contrast mammography would be a suspicious lesion or a malignant lesion in a young patient under 40 when we're concerned for malignancy and we would want to do mammography anyway. So this is the oblique view in the same patient. The breast is dense, and we can see this vague asymmetry if we look closely in the left upper breast, which correlated with the lump on ultrasound. When we look at the recombined contrast enhanced mammogram image, we clearly see this is just normal background breast tissue, this area in the left breast, which matched the area on the ultrasound. So it gave us important information. Another patient is a 44-year-old patient, again, presenting with a vague left breast mass here. It was so big that we had to take 2 pictures to measure it. An ultrasound showed what we call multifocal disease, i.e. more than one area involved, and lymph nodes. She's gone on and had a mammogram and contrast mammogram and MRI, and let us see. This is the same patient. This is her standard 2D mammogram showing just very dense breast, and very little information can be revealed. When we look at the recombined contrast image, we clearly define the limits of the mass on the left, and we can see there is no abnormality on the contralateral right side. This is the craniocaudal view on the same patient, showing a normal right breast. This is the standard mammogram. We get a vague abnormality here, but when we do the recombined image, we clearly define the abnormality in the lateral left breast. And just to show that this is what the MRI on the same patient looked like, nothing on the right on the breast MR, but there's this long segmental abnormality in the left breast. And if I go back, we can see that looks exactly like the contrast mammogram, and not much was seen on the standard mammogram. So why is this advantageous? Well, for patients to have MR, they need to go off to either a tertiary centre or wait for an appointment in their own centre. MR is timely, it's costly, and it can reveal to many false positives, as it's oversensitive and less specific. However, the contrast mammogram can be performed at the same visit in the same building at the same time. This significantly shortens the patient pathway. It enables us to stage a patient on the day of presentation. And if we find abnormalities in the contralateral breast or elsewhere that we hadn't suspected, we can complete all the investigations on the same day or bring them back the next day. So the eligibility criteria, what are our indications? Well, in patients over 40, if they've had their mammogram and we suspect cancer and they have dense breasts obscuring the background, we can then perform a contrast mammogram. In young patients under 40 who've been diagnosed with cancer on ultrasound, because we have to remember that under 40, we will start with breast ultrasound. And if we find a cancer, we will then proceed to a mammogram. Well, this is the ideal population when instead of just proceeding to a normal mammogram, we proceed to a contrast mammogram when we go to get significantly more information. And then we have patients over 40 with normal findings on a mammogram, but we suspect cancer on an ultrasound. So they may be ones with a dense breast. We've seen the cancer on the ultrasound. We can't see it on the mammogram. The contrast mammogram may give us the information where it is if it's obscured. And then we have patients over 40 diagnosed with cancer requiring further investigation to work out the size or how many abnormalities that are multifocality. And this group we call local staging. Contrast mammography is excellent in this group and may avoid the need for any MR. And again, there's a population of women that may present with an occult breast cancer, i.e. they present with an abnormal lymph node in the axilla. And we have done the biopsy and confirmed a malignant lymph node with a breast origin. We cannot see it on the mammogram. In this group, contrast mammography may reveal a small primary. It is also used where we wanted to do MR and it's contraindicated or not tolerated. And if there's concern about differentiating a postoperative scar in the breast or tumor recurrence, a scar will not enhance, whereas a tumor will. There is a role for contrast enhanced mammography to evaluate response to chemotherapy. So we can work out how big a lesion is before we start the chemotherapy and then at the end of chemotherapy. And we're currently doing this with MRI, but this will avoid the need for the MRI. And then another last group is what about high-risk screening, where they have a greater than 20% lifetime risk. So, so basically in this group, if they can't have MRI, then we may consider doing it in high-risk screening. But we just have to be careful that they're not radiation sensitive group. And then the last one is if we've got problem solving. So we're really not sure. We've had an examination and imaging and nothing really makes sense. Then a contrast mammogram may be useful in problem solving. Now, why wouldn't we do a contrast? We always have to consider contraindications. And again, I mentioned at the beginning the renal function. So we wouldn't if we had known kidney disease, such as a renal transplant. We have to be careful in diabetic patients and patients taking metformin. We wouldn't do it. We are unable to do mammograms, contrast mammograms in pregnancy and breastfeeding. And then there's the group that are allergic to the iodine-based contrast. And as always, patients that cannot tolerate a mammogram, cannot tolerate a contrast mammogram, and those are unable to give informed consent. We would not be able to do it in that population. So to summarize, the advantages of contrast mammography are it's useful for the dense breast. It's useful for problem solving in indeterminate images. We can do it immediately, and we can do local staging immediately on the day of presentation, unlike MRI. It's not menstrual cycle specific, unlike MRI, so we can do it at any time of the month. If we find an abnormality, we can proceed to second look ultrasound on the same day of attendance, unlike MRI, where MRI departments are remote from breast imaging centres and the patient will have to make an appointment to return. So contrast mammography is cost effective because it shortens the patient pathway. The sensitivity is similar to breast MRI, but the specificity is better, i.e. really only abnormalities and cancers light up with the contrast. It also has a much faster reporting time than MRI, where we have over 2,000 images compared to 8 images with a contrast mammogram. In summary, contrast mammography is more sensitive than a standard mammogram. It is excellent in dense breast tissue, which is why there's a lot of interest in it in young women and women with dense breasts. It's more specific than breast MRI. It's quick, readily available. It will shorten the patient's pathway and reduce the number of multidisciplinary discussions and reattendance appointments. So ultimately, the patient will get their treatment quicker, and ultimately it will save money. Thank you.